Our first speaker will be Karen Joynt Maddox from the Washington University School of Medicine in St. Louis, presenting about rural-urban disparities and spillover effects of COVID-19. Karen, I'll turn it over to you.
Great. Thank you so much. It's an honor to be part of this group. It's been wonderful to hear about all the amazing work that's going on, and we're really excited to add our little bit to the table here. There's certainly some overlap between what we're doing and what other folks have done. So I've already learned some things that will help us, and I hope some of you will see some potential for collaboration in what we share as well. Also, I very much appreciate the pet pictures, and if any of your pets are feeling bad about gaining weight in the pandemic, it's okay, we all did. All right, let me try to share. Make sure I share the right presentation here. All right, are you seeing the right one or the wrong one?
You look good.
Okay. All right, let's see here if I can advance it. Okay, so here's our team. I have co-investigators from Beth Israel and from the Harvard School of Public Health and from Brigham and Women's Hospital, as well as two amazing analysts and statisticians from my team here, RJ Waken and Function Wang. And we are excited to start our project. I will be totally honest and say most of what we've done so far has been the DUA, which is a long process in getting Medicare data. So we've got no results to share, but we have a lot of initial sort of data wrangling and code going. So I hope we'll be able to share stuff before too long. But as you all know, these projects were spurred by concerns about the sort of beyond the main effects of COVID. And so our focus is on people living in rural areas and thinking about their cardiovascular disease outcomes. Cardiovascular disease was picked because I'm a cardiologist, but it's emblematic. Really, we plan to be able to leverage some of what we put together to think about a broader array of health conditions once we sort of work out the kinks on one. But we also know that rural individuals have much worse cardiovascular outcomes than their urban counterparts, and those gaps have been widening quite a bit recently. And so it sort of presents an opportunity to bring together some streams of work for us around investigating both gaps with urban-rural health and also sort of the intersectionality of how race and poverty contribute to those. So the central premise of the project is that understanding the spillover effects of COVID on medical care in rural areas might help us identify key gaps and vulnerabilities in rural health delivery. And maybe if we can find strategies that helped alleviate some of that, better deal with similar outbreaks or other challenges to rural healthcare delivery in the future. Our hypothesis is that rural areas were hit harder by COVID spillover and had less use of what we're calling spillover mitigation strategies. I should have thought that out before realizing I'd have to say it out loud a bunch of times. And that those differences were associated with worse short-term and long-term non-COVID health outcomes. So a few definitions. When we're thinking about spillover, we've subdivided those into 4 groups. Delays in acute presentation. So someone, for example, not coming in when they start to have chest pain. Disruptions in acute treatment. So someone, for example, not receiving a stent for their heart attack or other revascularization for a stroke. Deferrals of usual outpatient care. So folks not being able to come in for their diabetes or hypertension or heart failure visits. And then worsening social risk. And I've learned a lot from all of you today about how we're going to think differently about quantifying that. We then are thinking about mitigation strategies, not in terms of mitigating COVID itself, but in terms of mitigating the spillover effects. So things like using telehealth, be that in an ICU or a consultative or outpatient setting, reinitiating cardiac procedures, for example, when everything shut down initially, some places were faster than others to be able to quickly prioritize and restart things that needed to get done. Population health management tools, so thinking about people's exposure to alternative payment models, to other things that might enroll them in population health management, and then some of the financial support for hospitals and clinics that was available to keep them open. Our first aim is to quantify these spillover effects and mitigation strategies in rural compared to urban areas. I'll skip through the hypotheses because I sort of already talked about that. Our second aim is to quantify the short and long-term clinical effects of those those spillover and mitigation events and how they interact with each other. And again, we hypothesize that will be worse in rural than urban areas. And our third aim is to look at the short and long-term clinical effects of the deferral of the chronic care. So we it's sort of a matrix. It's a 2x2, but we sort of group the aims into looking at the effects of disruptions to acute care and chronic care. So we're using Medicare data for this. We are on the VRDC, which allows us Medicare data up to about 2 quarters old. So for a different project, we're on doing some nursing home COVID stuff through actually early 2022. So we will be able to track a lot of these outcomes out for a reasonable amount of time once we get everything up and running. Also, because it's national data, although fee-for-service is becoming less and less, it does get the majority of the population in most places. We've actually, we're trying to actually update the data request to be able to get some Medicare Advantage data to see how sensitive some of our findings are to whether or not we can include the emerging encounter data for Medicare Advantage, which isn't available out as recently, but could give us a little bit of fill-in on that. My slides decided to stop moving. There we go. So the outcomes for each of the aims are, as I mentioned, in aim 1 to actually quantify the spillover and mitigation themselves, and then in aim 2 to take those and use them to examine things like out-of-hospital death or in-hospital mortality that we think might be the sequela of disruption of acute care, or longer-term new heart failure, new long-term care residents, or things that would reflect a longer-term sequela of care disruption. And for aim 3, it's using the same predictors, but then looking at ambulatory care sensitive conditions, preventable emergency department visits, and then the development of cardiovascular disease or hospitalization based on having missed care for diabetes or hypertension. The specific details of the methods are probably not of terrific interest to anyone right now, but we're actually thinking about this at the county level, because you can't, the people that had heart attacks last year are probably not going to have them next year, or at least they're not the only people who are going to have them next year. So we need to create a denominator from which to be able to examine sort of the counterfactual. And so we're using patient level models to create county level data. We have some methodologic attempts at trying to account for the fact that the farther we get into the pandemic, the more that our heart attacks and heart failure patients will have died from COVID. And so we do need to do a little bit of work methodologically to make sure that the sample actually represents sort of an appropriate group to follow over time. But once we build the county level data, we can find, for example, a 10% relative decrease in revascularization for heart attacks in a rural county compared with a 5% decrease in an urban county, or something to that effect. And then we can use fairly straightforward regression to compare between urban and rural using spatial random effects and other methods to control for the fact that our counties are not unrelated to each other. In 2 and 3, we basically then take those items and use them as predictors to be able to follow folks forward. So if you're in an area with a certain amount of penetration of population health, for example, some of these we're also going to test out at the patient level. It's a little complicated to write into a grant that way, but figuring out how we can sort of merge patient and county level data is going to be realistically how we try to get this done. And then we can actually put the measures into the models together. So to determine whether or not counties with greater growth in telehealth, for example, had lower short-term increases in in-hospital mortality. We don't have any results yet, so I have nothing to share, but stay tuned. We're sort of building this out, and I hope that once we get it up and running, we'll have some interesting stuff, and hopefully we'll overlap a lot with stuff that the rest of you are doing. And so though we can never share patient level data, hopefully we will be able to share some of the more aggregated changes in health status that could intersect nicely with a lot of what other folks are doing. Thanks very much.